Hello. So the first recording is going to include chapter 7 and 9. So chapter 7 is models for working with psychiatric patients. So there's a couple objectives. We're going to compare and contrast major therapeutic models that contribute to the understanding of psychiatric patients and their needs. We're going to identify key concepts of major therapeutic models and then describe the relevance of each of the therapeutic models of psychiatric nursing practice. So first, we're going to talk about the recovery model. And this involves improving the patient's competencies, not simply alleviating their symptoms. It's definitely not a medical model. It does not involve a cure, but movement toward a meaningful way of life. Patients striving to improve his or her own health and wellness, striving to achieve the full potential of life, and there are 10 guiding principles of the recovery model, which includes that it's person driven, it occurs via many pathways, it's holistic, it is supported by peers, it's culturally based and influence, it's supported by addressing trauma, it is strength based and based on respect and emerges from hope. So again, it's person driven and self directed. There's collaboration with the consumer instead of telling them what to do. It encourages them to try new things, and it's the consumer taking responsibility for their own care. The recovery being nonlinear, setbacks are not considered as failure. It's creating an atmosphere of hope. The person is not identified by his or her illnesses. The person is not, so you wouldn't say the person is bipolar. The consumers develop meaningful roles in their communities, not with the mental health system. Their support systems would include their family members, their peers, and the community members. And peer support is essential. The relevance that it has to nursing practice is that the assessment focuses on the consumer's perception of mental health and the desire to make changes for their recovery. The consumer is incorporated in every level of the planning, the training, the delivery, policy, and evaluation of the mental health care services. Nothing about us without us is the motto. Sonia, a surgical wing nurse, struggles with major depressive symptoms and mood swings. Robert, a fellow nurse, has been Sonia's peer-to-peer counselor for 5 years. Lately, however, Sonia has become symptomatic and began to yell at Robert, berating him. In fact, as her anger has escalated, she has began to threaten Robert. Recognizing her violence is escalating, Sonia asks Robert to accompany her to the emergency room, where she is subsequently admitted to the behavioral care unit. After saying goodnight to Sonia, Robert stays behind to ask to be part of the treatment and discharge planning team. So, following the recovery model, what is the best response to Robert's request? Would you say no? It's obvious that he is not a good fit for Sonia? Would you explain that first it's crucial to find out what he did to anger Sonia? Would you consult with Sonia to get her permission to add Robert to the team? Or explain to Sonia that Robert's input is invaluable to the team and so he must be allowed to participate? So the correct answer, oops, sorry. All right, so I can't go back. The correct answer was C. Peer-to-peer relationships are part of the recovery model, and they are very powerful motivators for both peers. But Sonia needs to be given the choice whether she wants to continue to have Robert as a peer-to-peer partner. So after Sonia would agree to continue the peer-to-peer relationship and given HIPAA permission for Robert to be involved in her care, he can attend discharge planning meetings on Sonia's behalf. So then Case study 2 is Robert demonstrates genuine care for Sonia, but it isn't an immediate yes, but it's not a no either. Peer support is crucial to the recovery model, and there's no doubt that Robert's long history of a good working relationship with Sonia makes him invaluable to the team. At the same time, it is also essential to the recovery model that the patient take responsibility for their own care and be included at every phase of the planning, implementation, and evaluation. Next, we're going to talk about attachment theory. This is where it's believed that humans have a natural tendency to develop intimate emotional bonds throughout life, that humans are motivated by a need for relationships, and it's found to be associated with developmental and personality and mental disorders. Development of psychiatric disorders can occur as a result of childhood trauma. Sigmund Freud emphasized the unconscious process of psychodynamic factors for motivation and behavior. It's self-psychology, whereas every human being longs to be appreciated. The object relations theory is that individuals relate to others based on expectations formed by early life experiences. In early parental relationships, if early parental relationships are secure and loving, the child grows up to be in a secure relationship. Versus if disruptions in early child parent relationships lead to future relationship problems by distorting their perception of others. The consciousness versus unconsciousness. The consciousness is where information within the person's awareness. The unconscious are memories, conflicts, experience, and the material that have been repressed and cannot be recalled at will. The preconscious are memories that can be recalled to the consciousness with some effort. Insight about the meaning of symptoms facilitates change. Now we're going to talk about defense mechanisms. When anxiety becomes too painful, defense mechanisms are used to project the ego and diminish the anxiety. Excessive use of defense mechanism prevents the person from problem solving, though. Defense mechanisms are unconscious, some are within voluntary control. Transference is when the unconscious distortion in the relationship, a patient would displace their distrustful feelings for their father to her male psychiatrist and refuse treatment. Projection is unconsciously or consciously attributing one's own repressed thoughts to someone. An individual often projects this to the second person who reacts to the projection, and then the reactivity elicits a response from the first person. Denial is an unconscious refusal to admit an unacceptable idea or behavior. Repression is the unconscious and involuntary forgetting of a painful idea, event, or a conflict. Suppression is the conscious exclusion from awareness of anxiety-producing feelings, ideas, or situations. Rationalization can be a conscious or unconscious attempt to justify one's feelings or behaviors. Intellectualization is also a conscious or unconscious logical explanations without an affective component. Disassociation is an unconscious separation of painful feelings and emotions from an unacceptable situation, object, or idea. Identification is the conscious or unconscious attempt to model yourself after a respective person. Introjection is unconsciously incorporating values and attitudes of others as if they were your own. Compensation is consciously covering up for a weakness by overemphasizing or making up a desirable trait. Sublimation is consciously or unconsciously channeling instinctual drives into acceptable activities. Reaction formation is the conscious behavior that is the exact opposite of an unconscious feeling. Undoing is the unconscious return to an earlier, more comfortable sorry. Wrong slide. Undoing is consciously doing something to counteract or make up for a transgression. Displacement is unconsciously discharging pent-up feelings to a less threatening object. Projection is unconsciously or consciously blaming someone else for one's difficulties. Conversion is an unconscious expression of intrapsychic conflict symbolically through physical symptoms. And regression is the unconscious return to an earlier, more comfortable developmental level. So Sonia recalls a recent incident at the hospital unit where she works. She came to work angry after arguing with her mother over the phone. Coworker Zoe started to give her the report after a challenging night, and Sonia became angry with Zoe for being so detailed. Just hurry up so I can see the patients for myself. Zoe then became angry as well. They argued about the report, each bickering during the time it takes to actually give a report. Both nurses blamed each other. So, which of the following did Sonia and her coworker Zoe most clearly exhibit? Projection, conversion, introjection, or transference? And the answer is A. Sonia unconsciously projected her anger towards her mother to Zoe. Zoe was responding to Sonia's angry, critical behavior after a challenging night by arguing back. The needs of the unit were not met at that point because of the projection. To stop this behavior, either one of the nurses should take a deep breath and go back to the task at hand, which is the patient report, and another staff member could also have guided both nurses back to the task of giving and receiving the shift report. Projection is often difficult to identify because the intense emotion is often due to a different issue than the one currently being discussed. Now we'll talk about the relevance to the nursing practice. So brief therapeutic encounters a nurse must recognize and understand would be maladaptive defense mechanisms. They should share observations regarding the defense mechanisms, assist the patient to increase awareness about use of defense mechanism, and also increase the use of adaptive behaviors. Next, we'll talk about the developmental model. Erickson built on Freud's psychoanalytic model that every person passes through 8 interrelated stages over the life cycle, and failure to complete one stage results in reduced ability to cope psychologically. So we have trust versus mistrust, and that occurs between birth and 18 months. That's where they're developing realistic trust of self and others. You then have autonomy versus shame, and that's 18 months to 3 years. And this is where you're developing self-control and willpower. And then the initiative versus guilt, which is 3 to 5 years, this is where they're developing an adequate conscience. And then industry versus inferiority, ages 6 to 12 years, is where the feeling of self-acceptance occurs. Patients with psychiatric disorders demonstrate partial mastery of developmental stages. The nurse needs to conduct an assessment of the patient's level of functioning. During the assessment, you need to identify the degree of mastery of each stage up to the patient's current age. The assessment would reveal issues to be addressed while working with the patient. The interpersonal model, Sullivan's, where his background is psychoanalytic and he believes that the interactional is more important than the intrapsychic. A healthy person is a social being with the ability to have a relationship with others. Mental illness is the lack of awareness or a lack of skills in interpersonal relationships. Relationships are viewed as a source of anxiety, maladaptive behavior, and negative personality formation. The interpersonal psychotherapy, or IPT, is used to treat depression and other mood disorders. It addresses stressful social and interpersonal dynamics associated with the depressive symptoms. It also improves social functioning by examining interpersonal disputes, role transitions, grief, and interpersonal deficits. The nurse's role would be to focus on the current interpersonal relationships and experiences. They develop mature and satisfactory relationships relatively free from anxiety. And the nurse-patient relationship is used as a vehicle to analyze the patient's interpersonal process and test new relationship skills. It focuses on interpersonal issues and the distortions due to past experiences. The nurse's role is to correct the distortions using clear communication, consensual validation, and warm collaborative relationships. The present patient, you need to present the patient as being worthwhile. You need to respect the patient's rights, dignity, and valuable abilities. Focus of sessions is on loneliness, fear of rejection, clarifying emotions, and the use of anxiety to learn about self and others. And it's a time-limited therapy, which is usually 3 months. Peplau elaborated and added to applied Sullivan's concept of degrees of anxiety to nursing. He also described effects of anxiety on perception and learning. The nurse's role, as described by Peplau, is to decrease the patient's insecurity and improve functioning through interpersonal relationships. Next is the cognitive behavior model. Beck's cognitive therapy and Ellis's rational emotive therapy models focuses on thinking and the behavior rather than on expressing feelings. The cognitive approach is the ability to think, analyze, judge, decide, and do. The irrational and illogical beliefs responsible for causing emotional problems is also focused. The reoccurrence of irrational thoughts produces an emotional disturbance that keeps the dysfunctional behaviors apparent. The purpose of the rational emotive therapy is to stop blaming their self and to accept their self and attack the problems from a cognitive, emotive, and behavioral standpoint. So cognitive therapy and rational emotive therapy both focus on thinking and behaving rather than expressing feelings. Rational emotive therapy teaches the individuals to stop blaming themselves and to accept themselves as they are. It attacks problems from a cognitive, emotive, and behavioral standpoint by using the ABC theory of personality. Behavioral therapy, or BT, builds on cognitive therapy with principles of classical and operant conditioning. It uses reinforcement, skills training, response prevention, exposure, which would be in vivo or imaginal, and also systemic desensitization. Cognitive behavioral therapy is effective in directly changing behaviors as well as changing faulty thinking. It's the most evidence-based therapy. Motivational enhancement therapy is a variation of CBT where it enhances the patient's readiness and willingness to change habits and the relation to addictions using motivational interviewing. Dialectical behavioral therapy, or DBT, it's used to treat borderline personality disorders and complex post-traumatic stress disorders. It decreases the parasuicidal behavior of self-mutilation and also suicidal attempts. The nurse's role is a collaborative effort to achieve goals for improving self-esteem, coping, relationships, and lifestyles. Humor is used to confront ineffective thinking, and the focus of therapy is on the present. The patients learn to take responsibility for their irrational thoughts, their feelings, and their behavior to replace these with more productive thoughts. Relevance to nursing practice is that you assist the patient to learn from their mistakes. Patients who project blame can be shown that they are responsible for their behaviors, and patients who focus on shoulds, oughts, and musts can be taught to act according to their personal wants and beliefs. So Sonia works with her therapeutic team to identify sources of her anger and anxiety. The chief of which is her tendency to blame herself and to become disgusted with herself for all her flaws and imperfections. So, which therapy helps patients stop blaming themselves and to accept themselves as they are using the ABC theory of personality? The motivational enhancement therapy, the dialectical behavioral therapy, the cognitive behavioral therapy, or the rational emotive therapy? And the answer is D, the rational emotive therapy. This again teaches individuals to stop blaming themselves and to accept themselves as they are with flaws and imperfections.